Thanks, Rose. That's very nice. So everybody always says they're really excited to introduce the speaker that's going to go next, but I really am. If you probably can't tell, I'm really geeked out to have Mark Grinstaff here. Mark is a polymath in every sense of the word. He is a distinguished professor of translational research at Boston University. He's affiliated with the BME department, the chemistry department, the material science and engineering department, and the School of Medicine there. So he's got a lot of hands and a lot of pies, which is fantastic. He is the Nanotechnology Innovation Center director there at BU. He's also directs the T32 program in Biomaterials at BU. He received his PhD from the University of Illinois with Ken Suslick, and he completed a postdoctoral fellowship with the inimitable Harry Gray at Caltech. So again, demonstrating his flexibility intellectually. Mark's won a ton of awards, as a lot of us probably already know: the ACS Nobel Laureate Signature Award, the NSF Career Award, Pew Scholar in Biomedical Research, Clemson Award for Applied Research, Camille Dreyfus, Alfred P. Sloan, Edward Kennedy Award for Healthcare Innovation. He's a fellow of the American Institute of Medical and Biomedical Engineering, fellow of the RSC, fellow of the American Institute of Chemists, and it goes on and on and on. So it's no understatement to say that we'd be here for a while. I went through everything. So he is an author or co-author on more than 350 peer-reviewed articles, and I think that might be a conservative estimate. He's given more than 300 oral presentations, more than 200 patents or pending applications. He's co-founded several companies, and I think he'll have a disclosure there at the beginning. I think I saw a quick preview of it yesterday to tell you about some of his potential or perceived conflicts in a good way. His current research activities involve the synthesis of new macromolecules and biomaterials, self-assembly chemistry, imaging contrast agents, drug delivery, and wound repair. So as I mentioned, I am thrilled to segue to Mark Grinstaff, who I'm sure is going to deliver a really fantastic and really stimulating talk. Mark, thank you so much for being here, especially during the strange.
Eric, thank you very much for the kind introduction. It's a pleasure to share with you, all of you, via the web, the research that we're doing. I would very much love to be in Atlanta right now. As I look outside, I have a foot of snow, and it has not been above 0 for 2 weeks. So trust me, I would love to be there and to share all of this with you in person. As was mentioned, my interests are quite broad, but it's always about the underlying molecular science and engineering principles and using those principles to really solve problems in society. Before we start, I do have a couple disclosures and conflicts of interest. I've been fortunate with my students and postdocs to form a number of companies and spin out technology to the clinic and to the real world. Early on, I co-invented Abraxane, which is an FDA-approved treatment for late-stage lung cancer and breast cancer, the standard of care. And more recently, developed a suite of surgical adhesives that are used to repair the dura and the spine. And of course, when you're young, you have all these exciting ideas about, how you could create new technology and move it into the clinic. And so you're really excited about life. And then when you get your first FDA-approved product, again, things are going great, and you're thinking about that next technology and what you can do. And when you get the second one, you're a little bit older. Things are changing a little bit more gray hair. But again, quite exciting. And we have another technology that's getting close to the FDA, and yet I'm a little concerned with what's actually going to happen if I actually get a third product approved. But nonetheless, doing basic research and thinking about how we can get that out to people and to help them is what is really important. So today I'm going to share with you 3 short stories that kind of highlight the way we select a challenge, solve a problem, and work with clinicians. And the goal, as I mentioned, is always about understanding the molecular science and engineering principles that are there, and then using that information and our creativity to come up with new solutions and new ideas. And the first story is in the area of wound care, and we're going to talk and discuss about ocular wounds and how one goes about repairing those wounds today. And then we'll move on to lung cancer, and in particular early stage lung cancer, and how do we go about helping those patients, which is about 50,000 a year, in the treatment of early stage lung cancer. And then the last story will be about osteoarthritis, and how do we think about actually assessing the state of the disease, and can we develop imaging tools that would actually allow us to image the cartilage, which is around the long bone. And similarly, how do we think about treatments or therapies? So the first topic is on corneal lacerations. These are an ophthalmic emergency. They can be a result of trauma, infection, inflammation, or surgery. And so they are an emergency. One has to take care of this wound immediately to ensure that you don't lose sight. The standard of care, or what used to be the standard of care, is the application of sutures to close that wound. And of course, every time you take that suture and you put it through the tissue, you inflict more trauma to the tissue. If the sutures are not equivalent around that wound site, they will pull in different directions, and that will lead to an astigma. So that's a problem. If they get loose or broken, again, a problem. You have to be very highly skilled to do this because you have to treat this wound quickly and efficiently. And of course, sutures can be a site for infection or inflammation. And the sutures that are used are nylon-based, so you actually have to remove them in 1, 2, 3, 4 months later after the wound has repaired. And as you all know, pulling out sutures from a wound is going to inflict more damage to that site. I'm going to show 2 pictures, so if you'd like to look, you should look. If not, maybe look away from the computer screen. The first is a linear laceration that's through the eye here, and you can see all the sutures that have gone into place. And so this is really quite remarkable that someone's been able to suture this wound and secure it and prevent it. Of course, it's a little bit inflamed. That's an easy wound. Here is a wound from a BB that's gone into the eye, and of course the clinician is just doing their very best to try to close that wound. And our thought was there must be better ways to close wounds than using sutures. And so the idea was to come up with a corneal sealant or an adhesive that we can use that would be able to be superior to sutures, be easier, faster, and a better outcome. And so obviously you can set up a list of design requirements for your material. You want to secure the tissue in place. You want to have the ability to adhere to a moist corneal surfaces. You want to act locally in safety. You want to restore the intraocular pressure, maintain the structural integrity of the eye. You'd like to be a microbial barrier. You'd like your material to be able to flow through a very, very, very small needle so you could apply it to the site. And of course, you'd like it to be biocompatible. So our thought was to use a class of polymers called dendrimers to do this. And these are highly branched polymers. We're all very familiar with linear polymers. So a nice long linear chain has 2 end groups on it. One can have other architectures such as a comb polymer, or you can have these dendritic polymers. And in a dendrimer, you have a central core, and from that central core, it branches out. And so you have layers. And so it's like an onion. In each layer, we call it generation. So generation 0, 1, 2, 3, and 4, and so forth. They're very interesting macromolecules, and they have different properties than what you might expect with a linear polymer. So, for example, a linear polymer is a random coil. Tends to have high viscosity because you have chain-chain entanglement. Low solubility because you typically just have 2 end groups. And the structural control is not that good. Where in a dendrimer, these are globular structures, so much more like a protein in solution. They tend to have low viscosities because it's more like ball bearings, right? So you don't have that chain-chain entanglement. They have high solubility because you have all these end groups, and a high degree of structural control. So from a synthetic standpoint, I can make changes at the core, I can make changes along the branches, or I can make changes at the end. So the question becomes, what composition do you make? and what materials do you make that out of? So our thought was, let's build this complex dendrimer structure out of biocompatible building blocks, such that upon degradation, you would not invoke an immune response or an inflammatory response. It would be reasonably biocompatible. So can we use amino acids or carbohydrates or lactic acid or glycerol, which is in our phospholipids, or succinic acid part of the Krebs cycle? We all know polylactic acid. It really is every engineer's favorite polymer. All right, you can make it, and it's used in all these applications from tissue engineering to drug delivery. The downside is it's fairly hard to control that molecular weight. It's hard to do chemical functionality of that structure, and it's not the easiest to process or to dissolve. And so our thought was, if we could build this dendritic structure, we might have all the attributes that are favorable for polylactic acid, but have a structure that's much more amenable to derivatization and optimization. So here's one of our first examples. It's composed of succinic acid in red and glycerol blue, and it branches out. So we have our generation 0, 1, 2, 3, and 4. It's about 15 nanometers in diameter, so it's globular and it has this real structure. Now, for us to make a gel, we want to seal a wound, so we need to bring our materials together and cross-link them. And so our thought was, let's use some beautiful chemistry that was developed in the peptide world to make large peptides, where what you would do is you take one peptide with an N-terminal aldehyde and another peptide that has an N-terminal cysteine, and you can mix those two together at room temperature in PBS, pH 7.4, and you can form this thiazolidine linkage. And so it's a very nice, mild way to form a gel. And so our thought was, could we use something like a dendrimer branched structure that has N-terminal cysteines and some type of PEG dialdehyde, and if we mix those two together, would we actually form a gel? And the answer is yes, and it works really nicely and it works very efficiently. And so we made these N-terminal cysteine dendrons that have multiple branches on them, and if we mix them with PEG dialdehyde, we form this nice, clear, soft, elastic, adhesive material that would be ideal for sealing a corneal wound. So the corneal wound that we looked at first was a cataract. So this is a very common procedure. Millions are done each year in the U.S. And what they do is they go in and they make an incision in the cornea. They go in with a device and they basically liquefy your lens. They extract it out, and then they put back an intraocular lens and go forward. If you get an infection, it looks something like this, which is just downright horrible. But they don't secure this wound. And basically, it's called a self-closing wound. It's very clever. And if you think about the wound, this is the outside of the eye. This is the inside. If you look at how the wound is made, it comes across in a very long way and then comes down. And that means when you have high intraocular pressure, it pushes it closed, and you don't have fluid from the outside going in. So that, in a sense, is self-closing. The problem is that if the intraocular pressure fluctuates, then fluid from the outside can come in, and that can lead to an infection. And so our idea was, let's see if this material works as a sealant. So we made our 3 millimeter full thickness laceration or wound between these two purple dots. We applied our polymer sealant, and then we injected fluid into the eye to see at what point failure would occur. And with this self-seal process, it's around 25 millimeters of mercury. A single suture is like 50, and our sealant is way in excess. Your normal intraocular pressure should be like 12, 15. If you push on your eye, then maybe it spikes up to 50 or 60, or if you cough. And so we have plenty of adhesive strength to close this wound. And so in the lab, we're doing lots of different experiments. We're doing many types of ocular wounds. And we're thinking about how we can get this to the clinic. And so we formed a company called Hyperbranch Medical Technology, filed a number of patents, built up the team. Down here in the back row is Michael. He was my student in the lab who went to go work for the company. And they moved forward. And the first product is OcuSeal, an ocular bandage. And it's a revolutionary synthetic hydrogel bandage designed specifically for use on the eye as a protective barrier against mechanical irritation in post-surgical, post-traumatic, and non-traumatic conditions. All right, great marketing literature. I didn't write that, okay? And the point is that it seals the wound. So the clinical trial was really clever and smart. So when you do a cataract procedure, you make this well-uniformed incision. You would put in the lens, and then if you push on the eye, it will leak and fluid will come out. And so what we did is we closed the wound with the sealant, pushed on the eye, and the fluid didn't come out. So that showed our function. And so there we have a way to actually show efficacy and do it in a very, very straightforward process. Now, what was really clever was the device that was used. It's a paintbrush. It's the size of a pen. At the end of the pen is this brush. Inside here are two chambers that have our two components for our sealant. And you push it, you squeeze on it, the fluid runs out to the brush, and you paint it on the eye. And within 5 seconds, it seals and closes the wound, and it's really simple. And so the team at Hyperbranch went on to make a hernia mesh fixation sealant, a spinal sealant, and a dura sealant, and get those all approved. And those are used around the world, which is really quite exciting. Now, in the previous story, it was all about forming a hydrogel. Well, what about tearing a hydrogel apart? How do we form a structure and then dissolve it? And if you could dissolve a hydrogel, where could you use that? And so we got interested in burns and in burn management, and in particular, pediatric burn dressings. And as you all know, a number of children are burned every day in the U.S., and changing a burn dressing on an infant or a small child or a teenager is extremely difficult. And oftentimes with children, they anesthetize them to do the procedure. And so they'll anesthetize the child, take off the bandage, wake them up, anesthetize them, change the bandage, and go forward. And this is crazy. We should have a better way to remove a dressing where you have to cut and mechanically debris it to remove it. And so the idea is, could we design a system where you could spray on the bandage and then have an easy way to remove it? So a pain-free dressing change. And to do that, we're going to dissolve it. So we want to spray it on, and then when we need to change it, we're going to spray another aqueous solution and have it dissolve. And so, of course, in a second-degree burn, you still have the nerve endings there, and of course it can be quite painful for that change. And the idea we're going to use here also borrows from the biochemistry and peptide ligation community. In here, what you would typically do to form a large polypeptide is you could take one structure that, for example, has this thiol ester on it, and another polymer or peptide change that has this N-terminal cysteine. The thiol would attack. You'd form a new thiol ester, and then you'd have a sulfur to nitrogen acyl migration leading to the formation of this amide bond. And so we had the idea, instead of using this to connect polymers or peptides together, can we use it to degrade them? And can we deconstruct the hydrogel? So the idea is to form a hydrogel with thiol esters. And now we're simply going to add this small molecule, cysteine. And the cysteine is going to attack and cleave all of those thiol esters and replace it with an amide linkage and dissolve the hydrogel. So, of course, to do this, we're going to take a PEG NHS so we can form either an amide or a thiol ester. We're going to take a cross-linker that has amines on it or a cross-linker that has thiols on it. And if we take the thiol one and mix it with our PEG NHS, we form a gel. And in fact, that gel loses its mechanical properties if we add cysteine methyl ester down here. If I do the same chemistry with the NH-terminated system, it forms the amide, which will not be degraded. And of course, that's my pink line here, and it doesn't degrade. The materials stick to tissue, and you can dissolve them off in the presence of with cysteine, as shown here. So again, the green one can be washed off. We moved on to an in vivo rat model where we have a burn. We have a burn plus bacteria, or we have our burn hydrogel, and then we add bacteria. And if we look over time and at the end of the experiment, what we find is that on the surface of the wound, the eschar, are negative control, so this would just be burn with no bacteria. We don't have bacteria, a small amount. If we add bacteria, we get a lot of bacteria. If we use our hydrogel, we don't have much bacteria. If I look at the spleen to see if I have a systemic infection, sure enough, my positive control shows me that the site's been infected, and of course if I use the hydrogel, it drops back down and is protected. And again, this material adheres very well to the skin, and yet it can be easily washed off. And so what we've done is taken our gel and added some blue dye to it. And then I've just taken a cloth with a little bit of cysteine methyl ester in it and added it to the top of it. And then you can watch it slowly dissolve away half of that. And so again, it works really well. And I'm happy to say we've just completed our large animal pig studies, and histology looks great. And that was at the end of the year, and so we're working up that data, and we'll be submitting that paper hopefully here in the spring. So in this project, it was all about molecular structure and how we can create these exciting dendrimer structures and use them to make sealants that could be used in a number of different applications, from sealing a wound to using it as a dressing and going forward. In the second project, I'd like to tell you and discuss with you a little bit about lung cancer. And as you all know, lung cancer is the leading cancer death in the U.S. About 160,000 individuals die. About 200,000 individuals are diagnosed. And for early stage lung cancer, this is stage 1, stage 2, 2A, and 2B. And for those patients, delivery of chemotherapeutics is not standard of care. Standard of care is a surgical resection. And then one has to worry about recurrence. And so, of course, in an early stage lung cancer patient, you have the tumor. They would come in and cut out that tumor. But the problem is that you leave behind microscopic disease at the surgical resection margin, and then that leads to tumor recurrence. And in fact, the 5-year survival rates are very poor in lung cancer compared to other cancers such as breast or prostate. So if you take out a small amount, you do a wedge resection, your chance for recurrence is like 20%. If you take out the entire lobe, okay, then it's much lower. But then you've just compromised the lung function of your patient. So the clinician is trying to balance how much tissue to take away so you don't have recurrence, at the same time having enough lung function remaining after the surgery. And it's that balance. There is one therapy that's in trial where they actually sew in radioactive beads into the margin to sterilize it to prevent the recurrence. And this works really well. It decreases the rates of recurrence to like 2%. And it increases survival from 44 to 70 months. That's huge in oncology. Most first-line drugs only do a few months. So if we can treat patients earlier and sterilize that margin, we can do some significant benefit. We're going to use a simple drug. We're going to use paclitaxel. It's used to treat lung cancer. And we're going to deliver that drug at that resection margin. So that's really the goal. Can we develop the new standard of care for preventing lung tumor recurrence? And if I can prevent the tumor recurrence at that resection margin, can I also maybe prevent it from leading to the lymph nodes and metastatic disease? And so our idea is to develop a device that fits into standard of care and allows us to directly treat this tissue at greatest risk for local recurrence. So what do? Well, a surgical stapler is used to do a wedge resection to remove that tumor. And what we're going to do is inside that surgical stapler, we're going to put a polymer film, and we're going to staple it into the resection margin so that drug elutes into the surrounding region to kill the remaining tumor cells. And this would be really a drop-in solution. So the surgeon's not going to do anything different except give treatment plus type of therapy. And to do this, we're going to use two polymers, two ones that we've made in the lab for the first time. One quite a few years back when I had a little bit more hair, and that are these poly 1,3-glycerol carbonates. And the second are these poly 1,2-glycerol carbonates. And the reason we pick these polymers is that upon degradation, you generate CO2 and glycerol. So unlike a polylactic acid, you're not going to generate this huge acidic response. And these polymers are made from a carbonate monomer that we can either polymerize itself or with lactide or caprolactone, and we can make copolymers. And these polymers degrade over a relatively slow process. The 1,2 carbonate systems we do by a copolymerization of this glycerol or epoxide intermediate and CO2. We make our polymer, and then we simply do a hydrogenation, and we get to our 1,2 glycerol carbonate. These materials dissolve a lot quicker. And so depending on your application and the time frame you need, you can think about designing this system so that it can stay around longer or less. And for this particular application in lung cancer, we chose the 1,3-glycerol carbonates, and we copolymerized that with caprolactone to make these copolymers. And then we simply attached a fatty acid to this secondary hydroxyl. And the net result is we can make films where the hydrophobicity of this film would vary based on the chain length of our fatty acid. So the longer the fatty acid chain length, the more hydrophobic the material is. And of course, our hypothesis was that that would slow the drug release. And so here we can look at the drug release as a function of our composition. And of course, the C18 elutes drug the slowest relative to the C14 or the C12. These materials are compliant, and one can actually staple and suture them into a site. And with this data, we moved on to an animal model where we would simply inject tumor cells into sub-Q into the mouse. We would grow the tumor up, we'd cut out the tumor, and then we'd randomize the mice, give our treatments, and look for tumor recurrence. And what's important here is we cut out all of the tumor, all right, and yet our controls, the tumor still comes back. And so if we do no treatment, all right, it's be our unloaded film, for example, tumor comes back. If I give paclitaxel IP, so a systemic delivery of paclitaxel, tumor comes back. Our y-axis here is freedom from local regional recurrence. If I deliver paclitaxel exactly to the site where the tumor was, the tumor comes back. If I deliver the paclitaxel in the film, then the tumor doesn't come back. All right, and so 80% of the animals are tumor-free after 90 days. And so what we're doing is we're delivering the drug locally and maintaining a high concentration of drug at that site. And in fact, that's exactly what we see when we do the PK and biodistribution study. With the film, the concentration of paclitaxel in the tissue stays fairly high, where if I give the drug IV, it falls off very quickly. If I look at the plasma levels, of course, with IV, it can be kind of high. It's there a little bit and then drops off. And likewise with the film, it's high initially, but then drops off. And so we're able to minimize the amount of drug that's going to be present there. If we look at the histology, if we use a film that has drug, we see no tumor being developed. And similarly, if we use a film that has drug in it, we get the tumor being formed. And I'm happy to say in this last year, we finally finished our large PK and safety studies in a pig, where we actually did a surgical resection of the lung, and then we measured the drug concentration as a function of distance from that resection margin. And what's important is we can go several centimeters from the implant site of this buttress and still have drug present there. And that's outstanding, because that means we're going to sterilize that region around this resection margin and prevent tumor recurrence. And in fact, if we look in the lymph nodes, we're actually delivering drug there, so it's draining into the lymph nodes. So then maybe we can actually do something to prevent metastatic disease. So again, in this project, it was about the molecular structures and how we think about those materials, and then how we use those materials for the prevention of lung tumor recurrence. Final story today is on osteoarthritis, and in particular, thinking about this disease, which is quite prevalent. So it is the leading cause of disability in the world. About 13% of the population suffers from osteoarthritis. In the US, it's roughly 30 million individuals. And in your knee, for example, you have this glistening white tissue, your articular cartilage. Performs two functions. It's a very smooth surface, and so you're able to glide when you're walking. And likewise, it can withstand compression. And so when you jump up and down, it will protect the bone. In OA, that cartilage has started to degrade away. You start to have bone-on-bone contact and a lot of pain. Well, cartilage is a really interesting material at all levels, from the macroscopic down to the molecular. And as I mentioned, it allows for this smooth gliding, so it has a very low coefficient of friction. It's able to support those mechanical loads and prevent damage to the underlying bone. And at the molecular level, you have all these collagen and hyaluronic acid fibers present. And then if you go down one step lower, or in more detail, you have your glycosaminoglycans. These are your GAGs. And the GAGs are negatively charged, and they hold on to the water. All right? And in fact, it acts like a sponge. And so when you push on cartilage, the GAGs and the water resist that. Likewise, the water and the GAGs allow for this very smooth surface. And we know from a number of animal studies and cadaver studies that when you lose GAG, that is a sign of early OA. And so if you had ways to detect GAG, maybe you could think about doing a proper diagnosis of OA. However, today, what do? If your knee hurts, my knee hurts, you go into the clinic, the doctor will ask you about your pain, they'll ask you about your mobility, how much can you flex, and then they'll do a plain radiograph. And of course, a plain radiograph looks at the bone. You don't see the cartilage tissue. So the tissue you're most interested in, you actually don't image. You image the bone. And what they do is they look for the distance between the bone. And if the distance is really large, they say you're healthy. If the distance is really small, they say you have OA. And they look for osteophytes, the little bony outgrowths. All right? And that's this current state of diagnosis. This works great if you have late stage OA. Doesn't work good if you have early stage OA. Doesn't help you. And we don't do continuous monitoring of your disease through imaging. Think about what we do for treatment of cardiovascular disease and how quantitative we are. All we're doing here is measuring a gap. You could imagine that if you lean one way or lean another way, it could be very different. I like maps. So let's map the cartilage. That's what you really want to do. I want to know the thickness. I want to know where the GAGs are. I want to know the equilibrium modulus. I want to build maps, and I want to use X-ray. And we're going to do contrast-enhanced computed tomography, CECT. And to do this, we're going to build a small molecule contrast agent that diffuses into the cartilage. And we're going to use that to image the cartilage. We're going to do one more thing. We're going to design our contrast agent so that it's cationic. And our GAGs are negatively charged, and therefore the positive charge will diffuse into the cartilage, and I'll set up a Donin equilibrium situation where every negative charge is reflected to a positive charge. Well, that means that I should be able to determine my GAG concentration from my CT image. And so again, if you're healthy and you have lots of GAG, so these negative charges, the positive contrast agent will diffuse in, and I'll get lots of signal. And then as the cartilage degrades and I lose my GAG, I'll get less contrast agent. If I use an anionic contrast agent, this is what's commercially available today for other indications. It doesn't diffuse in very much to healthy tissue, but it'll diffuse in a little bit more with degenerated early stage OA. But I would argue that the changes here for the anion are going to be much less than the changes in the dynamic range that I'll see for the cationic. We built a +1 contrast agent, a +2 contrast agent, and a +4 contrast agent. And the first experiment, we took a rabbit knee, soaked it into a solution of our contrast agents, put it into a CT scanner, and imaged it. And it was really exciting. All right, if you see here in red is the bone, but up here, that is the cartilage. And I can see the cartilage and I can see its thickness. If I do the same experiment with an anionic contrast agent, so little of the contrast agent is there that I can actually image the tissue. So no, maybe I can use a lot of fancy software programs and backfill data and try to generate a thickness. But this is a lot easier. I can see the tissue and I can measure the thickness and I can look for lesions. So the first experiment that we did many, but one of the first was looking at the ability of this contrast agent to detect OA in a human joint. And I got interested in the fingers. So they're a really good joint for a couple reasons. One, they're small, so I can actually do high resolution CT imaging. And two, the mechanics of the joint are fairly well described. And so I can do both equilibrium measurements, I can do mechanical measurements, as well as doing quantitative CT. And OA develops naturally in the hands. The current rate is about 1 in 12 in men and 1 in 4 in women. So I apologize for all the women out there. You're likely going to get it. My hypothesis is this rate's going to increase dramatically with all of us texting. And all the action that we do on a cell phone, I think we're going to wear out our joints. Anyway, so the first experiment was looking at a series of joints where we have different amounts of GAG. So we have OA, where we have minimal GAG. We have lots of GAG, where we have healthy tissue. And the anionic contrast agent is shown in these red open squares. And sure enough, it decreases with increasing GAG content, so that's good. But my slope is really shallow, and my dynamic range is really poor. The cationic contrast agent, again, low GAG, not much signal, lots of GAG, lots of signal, but I have a much bigger dynamic range. If I look at the equilibrium modulus, the same trend is there. So in the open black squares is the anionic, a fairly shallow slope, and not a great correlation. With my cationic contrast agent, I get a very nice correlation. So what we've been doing over the last couple years is moving this technology closer and closer to the clinic. So we've done mouse and rabbit. And lately we've been doing equine clinical studies and clinical trials and doing imaging both ex vivo and in vivo. And also looking at cadavers and looking at correlations. And again, we see very nice correlations between our CT attenuation values and our GAGs or equilibrium modulus. And of course, this idea translates over to other imaging modalities. So maybe you want to do MRI. You can build a cationic MRI contrast agent and it works the same. So we finally have a tool that allows us to be quantitative. Well, that opens up the idea maybe we can actually think about doing repair strategies and tissue engineering strategies for OA, but actually have ways of measuring success. All right? And so, again, we got interested in osteoarthritis. And again, it's basically pain meds early on. At late stage, it's a joint replacement. That's good for about 20 years. So great if you're 70, you get a joint replacement, fine. If you're 50 years old, you don't want a joint replacement. And there what they do is viscosupplement. In other words, they inject a hyaluronic acid product into your knee. And yet, excuse me, and yet these hyaluronic acid products have never been shown to be chondroprotective and protect the cartilage. They don't stay in the joint very long, and clinical trials show no improvement over placebo. It's like an 8%. That's nowhere close to getting approval. So the idea is, can we actually design a viscosupplement that would reside in the joint, lubricate it, dissipate the wear, and could I inject this with a 26 gauge needle as opposed to an 18 gauge needle that they do today? So we looked at hyaluronic acid, and we thought as a very crude model of this, or mimetic, we can make the following polymer where we have an ether linkage, we have our hydrophilic carboxylic acids, but we don't have this ether linkage that would be cleaved, and so we have a double bond. And sure enough, this resides in the joint a lot longer. And we can make this at several molecular weights, up to 10 million. And we know we want to be above 1 million so it doesn't diffuse out of that joint space. Our first experiment was a plug-on-plug coefficient of friction measurement. And so we have two plugs that are sliding against each other. And if we put in bovine synovial fluid, that's our positive control, the coefficient of friction increases and then levels off. If I do the same experiment with saline over time, 10,000 cycles, the coefficient of friction eventually increases and is high. If I use my biolubricant, the coefficient of friction remains lower. And in fact, I have less wear at my joint. So with this data, we set off to do a rat meniscal tear OA model, where essentially we go in and we cut the medial collateral ligament, and then we'll basically 1 week after surgery treat with either saline, Synvisc 1, which is the hyaluronic acid, or one of our biolubricants. And we collected a number of data. The first set we did was all histology, and we're only going to look at one of these figures today. So the first is down here, looking at the degenerative width of cartilage. And so if this is a larger value, that means you have more degraded cartilage. And if I do saline and I do Synvisc 1, there's no difference. So Synvisc 1 doesn't protect the cartilage, and you have the same amount of damaged cartilage. If I look at our biolubricant, all right, again, it actually dropped down. So we have less tissue damage, which is great, but we really don't see any type of dependence on our concentration or the dose that we're having. If we look at the histology in our sham, we can see the cartilage being degraded there. Our control healthy cartilage looks really good. If we look at our low dose of the biolubricant, maybe the cartilage looks a little better here. And similarly, at a higher dose, again, the cartilage looks okay. So again, we're able to get some type of protective effect. But this whole idea of thinking about a lubricant to lubricate the cartilage tissue surface and prevent wear was really exciting. And that opened up a cool project where we thought maybe we could actually make a single polymer that would act like a molecular ball bearing. And so with a good friend, Jay, we set out and we made a single dendritic polymer that's 9 million molecular weight. And it's actually 43 nanometers in diameter. And it acts as a soft lubricating material on tissue. So again, thinking about these ideas and how we can use material science, chemistry, and biomedical engineering to solve interesting problems. So again, we want to develop tools that allow us to do diagnosis, and we want to think about using those tools to think about developing and evaluating new therapies. So I'm going to wrap it up, but what we've learned over the time is, always be quantitative, ask lots of questions. Teams are incredibly important here. You want to have fun, ask for help. Communication is key. Learning to talk to people who are clinicians, engineers, chemists, everyone is important in bringing these technologies forward. And failure is fine. Just do it quickly and then identify what's right and move on. So I didn't do any of this work. I have a number of amazing students. I highlighted their pictures a little bit earlier throughout the talk. And then my collaborators, Terry Kim for the ocular work, Ed, Robert, and Ara for the burn. Yolanda Colson at MGH has been wonderful for the lung cancer project. And then Brian, Lori Goodrich, and Brad Nelson for doing all of the OA work. And of course, my group and all of them for their hard work and dedication. And I very much appreciate all of you attending the seminar today. And I would love some questions. And I didn't say a lot of things. So there should be lots of things. I'd be happy to answer any question about science, translation, or technology. So with that, thank you very much. And thank you again. Take care.